All right. Good morning, everybody. There are a few seats scattered in there. People still need space. Good morning and welcome to the Georgetown University McCourt School of Public Policy. I'm Karen Davenport. I'm a senior research fellow here at the Center for Health Insurance Reforms. For those of you who aren't familiar with our center, we're a team of national experts on commercial health insurance. We study the interplay of federal and state policies that affect how people access and use healthcare services. And we publish a plethora of research studies and reports, and also provide technical assistance to federal and state officials and other healthcare stakeholders. We're delighted to be here today for this third event in our series exploring the future of coverage that millions of Americans and many in this room rely on. Employer-sponsored health insurance is the backbone of the U.S. healthcare system, but it is under considerable strain. In this event series, we've been exploring the sources of that strain and policy options that can help ensure that millions of Americans and their families can maintain access to affordable, high-quality healthcare. Today, we are going to focus our attention on market competition and its role in controlling healthcare spending. In general, the U.S. allocates healthcare resources through a mix of market-based pricing mechanisms and government programs, which have greater ability to set prices. More than half of all Americans hold commercial coverage, and for these people, a well-functioning market is a key factor in how much they pay for health insurance and to access healthcare services. At the federal level, policymakers in recent years have focused on strengthening market infrastructure, such as requiring hospitals and insurers to post prices via price transparency regulations, while states have taken on everything from ownership transparency to limiting anti-competitive contracting behavior to restricting providers' use of excessive facility fees. At the same time, however, we see continued ownership consolidation among healthcare providers, leading perhaps to outsized leverage in price negotiations with payers, and the growing presence of private equity investors in the healthcare landscape, perhaps in response to incentives that favor investment returns over patients' well-being. Today, we're going to explore some of these dynamics and learn more about how and whether public policy can foster competitive healthcare markets and what impact this may have on price, quality, and access. I particularly want to thank our sponsor for today's event, Arnold Ventures, for their commitment to improving the affordability and quality of health insurance coverage. There are few issues more challenging and complicated, and they've taken it head on. A couple of notes on logistics. First, we're recording this event and we will be posting the recording to our website. We will also notify you by email when it becomes available, so please share it with all of your colleagues who can't be here today. And second, there will be an opportunity to ask questions. So when it comes time, just raise your hand and we will have some microphone runners in the audience who will show up at your side right away. Now, I would like to introduce Stacy Sanders, our lead-off speaker for this morning. Stacy currently serves as Chief Competition Officer at the United States Department of Health and Human Services. In this role, she works with the Federal Trade Commission and the Department of Justice, as well as her colleagues at HHS, to address concentration in healthcare markets and to develop policy initiatives promoting healthcare competition. Before joining HHS, Stacy most recently served as staff director for the Senate Committee on Aging, and she's also served as the federal policy director for the Medicare Rights Center. Please join me in welcoming Stacy Sanders.
Hi. Good morning, everyone. I'm Stacy Sanders, and I'm a counselor to Secretary Javier Becerra and also HHS's Chief Competition Officer. Alongside many leaders at the Department of Health and Human Services, I am entrusted with the task of making healthcare affordable, transparent, and fair for everyone. No more putting corporations before people. That is the charge of the president and of this administration. HHS is teaming up with the Federal Trade Commission and the Department of Justice to adopt a comprehensive whole of government approach to tackling market concentration within the healthcare sector. And the White House is doubling down on their commitment to leveling the playing field. We're talking about putting an end to corporate greed, whether it's through shady fees, price gouging, or slick marketing tactics. And as the president said himself in the State of the Union, we're coming for corporate malpractice. Nobody should have to choose between putting food on the table and getting the medicine that they need. Cancer patients shouldn't be left high and dry because of drug shortages. And nursing home residents should not have their care compromised by private equity companies. Because here's the thing, we believe that competition means lower costs, better pay and conditions for workers, and faster innovation. It's the key to a healthier and fairer future for all Americans. This administration is leading with results. We started by making hearing aids available over the counter, and we continued with the president's lower cost prescription drug law. The main thing to know is that we are working to put money back in the pockets of the American people so that they can afford their medications. We capped each covered insulin product at $35 a month for people with Medicare. Recommended vaccines, including shingles and RSV vaccines, are now available at no cost for people with Medicare prescription drug coverage. And we're proud to report that in 2023, 10.6 million people with Medicare prescription drug coverage received free vaccines. Annual out-of-pocket costs for prescription drugs are capped, helping the sickest people with Medicare who are paying the most for their prescription drugs to save thousands of dollars each year. Low-income assistance for people with Medicare Part D has expanded with improved benefits for people who need the extra help program. Drug companies are mandated to pay rebates to Medicare if their prices raise faster than inflation. And historically, Medicare for the first time is negotiating prescription drug prices. Finally, the enhanced premium tax credits under the Affordable Care Act have been expanded. Millions of Americans are saving on healthcare, and we're just getting started. Transparency is crucial to our competition agenda. It's the cornerstone of that agenda. And we're looking to shine a spotlight on every nook and cranny of the healthcare system. Through the Centers for Medicare and Medicaid Services, we're showing who is running different healthcare facilities. For the first time, we've released ownership data on hospitals, home health agencies, hospices, nursing homes, and more. We believe that researchers and enforcement agencies can figure out through access to this information how consolidation is affecting patients. And when it comes to nursing homes, we're looking specifically into private equity companies and real estate investment trusts. Because we believe that when Americans are making tough decisions about where their loved ones go, they deserve all of the information possible about who they are entrusting with their loved one's care. We're also looking to increase transparency in Medicare Advantage, where about now half of all people with Medicare receive their health insurance. And 5 insurers control over 70% of this market. This enhanced transparency is really about solutions. We're looking to promote the ability of people with Medicare Advantage to have timely access to care. We want to ensure that Medicare Advantage plans are appropriately using taxpayer funds, and we want the market to have healthy competition, including competition between Medicare Advantage and traditional Medicare. Regarding hospital price transparency, we're focused on making sure that hospitals meet their requirements to display prices, and we've ramped up our enforcement efforts to encourage that transparency and ensure it for patients and for the public. And finally, we've broken up the monopoly in organ transplantation that has controlled the organ procurement and transplantation network for its entirely near 4-decade history. Our commitment to transparency is unwavering because that is what the American people deserve. Again, we're looking to put people first, and it's important to us that we lead with listening and that we hear from the people in this audience and organizations like yours about what the White House and what the Department of Health and Human Services should be focused on. So we have a number of opportunities for the public to comment. Since the White House first announced its focus on healthcare consolidation in December, HHS and FTC, as an example, released an important request for information on drug shortages. We're looking for information about the practices of 2 middlemen, group purchasing organizations and drug wholesalers. We want to understand what role they play in the supply chain, and we want to know if they can be a part of the solution to drug shortages. The comment period for this particular RFI was extended to May 30th, and we encourage everyone to submit comments. But we're not stopping there. We also teamed up with the Department of Justice and the Federal Trade Commission for another request for information, focusing on the impacts of consolidation across the healthcare market. Research shows that competition in healthcare markets promotes higher quality, lower cost healthcare, greater access to care, increased innovation, and higher wages and better benefits for healthcare workers. The comment period for this particular RFI was extended to June 5th, and we encourage everyone to submit comments. Finally, going back to Medicare Advantage, our colleagues at the Centers for Medicare and Medicaid Services released a comprehensive RFI on data transparency in that program, with comments due on May 29th. So again, all of those comment periods are right around the corner, which is why it's really important that I encourage all of you to submit. Fair competition is what we're looking for in any market, but especially in one that has such an impact on Americans' lives. So again, we want to hear from you. We know we don't have all the answers, but we do have a powerful partnership between HHS, FTC, and DOJ that we want to leverage to the fullest extent. So we strongly encourage you to share your ideas for the administration, your ideas for Congress, and to help us prioritize so that ultimately we can meet our goal, which is to protect the American public, promote competition, increase transparency, and get people the health care that they deserve. Because as the president has said, capitalism without competition is just plain wrong. Thank you.
Thank you so much, Stacy. Stacy has graciously agreed to stay through the program, so she'll be part of our Q&A at the end of our time here. I would like to ask the panel to come up and get seated, and I will do some introductions for them too. So I'm now delighted to introduce today's superstar panel. It's going to be moderated by Kelly Hooper of Politico, who is very graciously agreed to do this on extremely short notice. So we are so grateful for her for stepping in. Kelly's work covering trends in healthcare cost and employer-sponsored health insurance, I think, makes her the perfect person to guide today's discussion. And you can find more information on Kelly in the insert for your brochure. For our panelists, we have David Seltz, who is Executive Director of the Massachusetts Health Policy Commission on your far right. And then Aaron Fusay-Brown, who is currently Professor of Law at the Georgia State School of Law, but soon to be Professor of Health Services Policy and Management at the Brown University School of Public Health. And then Charles Miller of Texas 2036. Their full bios are in your brochures, so I'll just note that they bring a range of experiences and perspectives to today's conversation. Their insights will help us explore how states approach the interplay between competition, affordability, and access to care. What kind of federal policies can help states advance market competition? And what are some of the greatest challenges states face as they make policy in this area? So please join me in welcoming and learning from these terrific panelists. Kelly, off to you.
Well, thank you for that introduction and good morning, everyone. We're going to have a discussion here about state-led efforts that are in the works to address consolidation in the healthcare industry. And then at the end, we'll open it up to the audience for a Q&A section. So have your questions ready for that. But to kick off our discussion, I have a broader question I'm hoping each of the panelists will share their thoughts on. So to each of you, how important is competition in the healthcare industry in terms of controlling costs? And Charles, maybe we'll start with you.
It's crucial. I think to address how important it is, I'll take on one of the criticisms of competition in healthcare, and that's we always hear that there's no competition when you're in an ambulance and you've had an emergency. And to a certain extent, that's true. But competition takes two forms. It's not just the patient themselves, it's also the institutional purchasers who are forming these payment systems that go on. And there can be contractually competitively negotiated contracts that go on for those emergency services. Even if the patient doesn't have the ability to choose them, there can be competition in those contracts that a patient is going to be bound by regardless. So it's important both at that individual patient level, but also at that institutional level.
Erin, yeah.
Great. So I think that competition, or the lack thereof, what we often call healthcare consolidation or market concentration, is what we know is the largest driver of healthcare prices and spending. So in terms of, if we could that there's healthcare costs. It's a very complex industry, but healthcare costs are largely driven particularly in the commercial market, by market power. It's not the sickness of the patient population. It's not the acuity. It's not even utilization or the use of services. It's market power and the ability to set prices at a level that is sort of above what the market would bear if you had healthy competition. And we know that that market competition doesn't function well in the United States in the healthcare space for a couple of reasons. The first is that most of the healthcare markets, particularly the hospital markets, but also increasingly physician specialty markets, we know the pharmaceutical benefit managers, insurance markets, we know that they are getting highly, highly consolidated and concentrated. So there's very little competition left in the space right now. And it's only getting more concentrated as time moves on. But the other thing we know is that healthcare, it sort of goes to Charles's example, is something where competition doesn't always function. Market forces don't function perfectly in healthcare anyway, because as patients, we are vulnerable and we don't know what we need. We don't know what something costs before we purchase it. And we can't really shop, right? You can't comparison shop for healthcare when you're in an ambulance or when your doctor just recommends you take a particular prescription drug. You don't know whether there's another generic alternative that would be equally or better for you cost-wise. So we know that the market forces don't work perfectly in healthcare anyway. And then we have on top of that an extremely consolidated healthcare system. And all of that adds up to an equation where competition or the lack thereof is the primary driver of rising, spiraling healthcare costs in the country.
David.
Good morning, everyone. Thank you, Kelly and the Center for having me. I'm David Saltz from Massachusetts. It's a pleasure to be here. In Massachusetts, we've been on this kind of multi-decade healthcare reform journey. I've been working in state health policy in Massachusetts for about 20 years. And back in 2006, we became the first state in the country to really take on this idea of universal healthcare access. We called it Romney Care at the time. And it was a success, and it became the model for the Affordable Care Act. And subsequent to that, we really have taken on this challenge of healthcare affordability and how do we bend the healthcare cost curve, understanding that this trajectory that we were on with healthcare cost growth was just unsustainable for us as a state. And so about a dozen years ago, we took this next big leap forward, really as a state focused on moderating spending growth. And there was some talk at the time about, well, if we want to moderate spending growth, why don't we just go back to rate setting? Why don't we just have government set all the pricing? Why don't we just have government run all the health plans? Why don't we just go to single payer? And those options were rejected at the time. And what we went for instead was still a reliance on a private market, still a reliance on competition to be able to drive that value. But an understanding that our healthcare market and our competition in the healthcare market was limited, and in some cases flawed, and in some cases not working right for patients and consumers. And so what we did is we wrapped around that private market and enhanced government oversight. And that enhanced government oversight was institutionalized through a new independent state government agency in the Health Policy Commission. That's where I work as executive director. And this new state agency had as one of its kind of cornerstones a function and a role about influencing the healthcare market and preventing some of those anti-competitive behaviors from occurring. And where we saw consolidation, could we steer that consolidation in ways that would maximize the potential positive benefits while minimizing the negative benefits? We've been at this for 12 years. I think we've learned a lot of lessons, and I'm excited to talk about them in the course of the panel today.
Thanks, everyone. Erin, I want to dig a little bit into a point you made, which is that, that healthcare industry is already highly consolidated and it's only getting more consolidated. So can you talk about, why we are seeing so much consolidation in healthcare now, and what are some of the biggest drivers of that?
So I think some of the biggest drivers of consolidation are consolidation itself. So if all of the other players, your competitors in the market are getting bigger, then in order to survive, if you're a community hospital, if you're a small physician group, you need to also join something big and powerful in order to survive. So in some ways, market consolidation was driven by the economic incentive of the bigger you are, the more pricing power you have in the commercial market. That means you can command higher prices. You can get more revenue. You're more powerful when you sit down at the negotiating table with those insurance companies to negotiate how much you're going to be paid for your services. So I think that was the initial driver. And then as competition erodes and consolidation gains force, then it becomes a reason in and of itself. In order to survive, you need to get big or join something else that's big, because something that is small can no longer compete. And then you kind of pour some gasoline on the fire when you add the well-meaning but value-based payment incentives that are created by this idea of knitting together the fragmented parts of the healthcare system in order to create value, care coordination, efficiencies, capitation, and all of these types of payment that shift risks and population health responsibility to the provider systems, to whether it's the health system or the physician groups, or encourages them to come together to assume risk for an entire population of patients. Now, in order to assume the financial risk of caring for a defined population of patients, you need to be big. You need to be big for a bunch of reasons. One is you need to be big enough to invest in the health information technology to track the data and measure the quality metrics and report and do all of the things you need to. And you need to be big because that's how insurance works. You can't spread risk among a small group. You need a big population. You need a big group of patients in order to be able to make it financially, manageable. Small groups we know are much riskier than large groups. So in some ways, we had this initial sort of like wave of consolidation that's been ongoing for decades now. And then you add to it in the last sort of 20 years or so, this move from fee-for-service to value-based payment models, which only in some ways intensifies new and different forms of consolidation, including vertical consolidation between, let's say, hospitals and physicians, or insurance companies and home health agencies, and PBMs and pharmacies, and all of these are now being rolled up into one giant conglomerate. And I think the reason we see consolidation is consolidation. We're at that point now where consolidation is the reason we have more consolidation.
Well, I want to move on to, how are states addressing that consolidation? So Charles, you've worked on efforts in Texas to address anti-competitive practices in healthcare. Can you talk about what strategies and solutions are gaining traction in the state, and, a little bit about what's working and what's not working?
Sure. So in Texas, we've been working on what we call our Healthy Markets campaign, and it's kind of the 3 pillars of what you need in a healthy market. You need them to be informed, competitive, and engaged. The informed part is transparency, and that's where we've seen a lot of the action. There have been efforts to make prices more transparent, to make the ability to get quality information to patients more transparent, as well as our work around getting an all-payer claims database set up. But transparency alone isn't going to solve the problem. As one of our legislative champions is fond of saying, if you only have transparency, you just know how badly you're getting screwed. You need choices, and you need the ability to, when you find out what that information is telling you, to go somewhere else. So you need competition and you need that engagement. One of the things that we did our last legislative session was pass a bill that prohibited certain anti-competitive contracting clauses. And this came about when we would talk with our larger employers in the state and said, well, this transparency information has come out. You now have access to prices and quality, and you guys kind of know where the high value providers are and where you should be steering your employees to start going and incentivizing them to go there. And they came back and said, well, we can't do that. We have contracting clauses with all of our provider groups that prohibit us from putting these in place if we want them in network. And this was, I think, one of the big insights for us, is that this vertical consolidation has actually created a problem where we talk about horizontal consolidation so much. And okay, if all the hospitals in an area merge and you only have one hospital left, that's kind of that horizontal consolidation. The vertical is when the hospital group goes out and buys up a provider group. Now, if you have a must-have facility in that hospital area, even though that might not be competitive itself, they are now leveraging that status of that hospital to come down and make the provider market less competitive through the use of these anti-competitive contracting practices. Even though there should be enough independent physicians in different physician groups for those to be competitive, if they are tying the ability to have that uncompetitive market, now you have that seepage. And so the lack of competition spills over. So one of the things that we want to do was ban these anti-competitive contracting practices. We were able to ban 4 different types. anti-steering clauses and anti-tiering clauses. And these are the things that employers wanted to put into their health benefit plans that would allow them to incentivize their employees to go to those high-value care. We banned gag clauses, which I think was a little bit redundant, but we weren't seeing a whole lot of compliance. So we did a little belt and suspenders approach there. And hopefully we'll see those clauses start to come out of the contracts. And then also the most favored nation. And this is where insurers, if they were the more dominant side in the equation, they were prohibiting any provider from offering a lower price to anyone else other than them. And so this was also creating the cycle of high prices. It just passed, like I said, last year. The rules were just recently came out implementing it. And we're going around talking to employers and kind of spreading the ability and availability of these new opportunities for them. So we're hopeful on it, but it's just a start.
And David, what about in Massachusetts? You know, what strategies are sort of gaining traction to promote competition there?
Yeah, thank you. I think we're a little bit more focused on maybe the institutional side of the competition, to use your phrasing earlier, and really focus on the provider side at the Health Policy Commission. So one of the first things that we did is to try to understand the landscape of our provider system. And that's actually an increasingly difficult question to answer. So we set up what we called a registration of provider organizations, which is a super wonky term, but basically means that we're trying to collect information about our major health systems and who they are, what is part of their corporate structure, who are they contracting on behalf of, who are they clinically affiliated with, who are all the boxes on their org chart, what is their governance structure, what are their finances at the highest corporate level. And this is not easy information to get and to understand. And so one is just trying to level set, like, what is the current complex structures of these major health systems in Massachusetts? And then second is, how are they changing over time? And so we have a process whereby if our major providers are proposing to have a new acquisition, a new joint venture, a new merger, an acquisition of a physician group, that they have to notice the Health Policy Commission, and we can review that transaction and review it and analyze the impacts that we think that transaction will have on cost, quality, access, and equity. And they cannot move forward on that transaction while we are conducting our review. In certain circumstances, we can conduct an even longer and more comprehensive review that can take as long as 6 months. And while we are conducting our review, again, that transaction cannot move forward. While we don't have the authority to block or deny a proposed transaction, what we can do and what we have done is provide public reports that comprehensively analyze and publicly report what we think the impacts of these are going to be. And we raise concerns about these transactions. And those can be used and have been used by our Attorney General's office, our Department of Public Health, in their enforcement activities and their enforcement authorities to either impose conditions on these transactions as they move forward. In some cases, the parties to these transactions have decided not to move forward with their plans based on the concerns that we have raised. But through this process, we have really provide a lot more sunshine and transparency to the public and to the marketplace about when these transactions are occurring, what the impacts are going to be, and what we can do to mitigate those concerns and ensure that these transactions are being held accountable to the goals that they're saying that they're going to do. Because a lot of times they'll say, oh, we're going to do this because we're going to have higher quality of care and we're going to be more efficient and we're going to succeed on value-based care. Okay, let's hold you accountable to see if you're actually going to be successful in this. And let's actually run the numbers to see if that's the case or if this is just a grab of more market share and more market leverage to increase pricing. Let's have that transparency and have that accountability at a statewide level. Now, Kelly, we've seen that alone can be impactful in changing market behavior, but we've also seen that it's had its limitations.
Got it. Thank you. I'm curious, and this could be for anyone on the panel, but where do site neutral payment reforms fit into this? And, you know, what are those types of reforms? What impact did they have on competition consolidation in the healthcare industry?
Go ahead.
I was gonna say, I can jump in on this. At a state level, we don't think of it as much about site neutral payments, except maybe in our Medicaid program. But in the commercial market, we talk about issues of facility fees where people are going to the same doctor they've been going to. All of a sudden, it gets bought up by a hospital system, and now they're getting a facility fee for what used to just be a regular doctor visit. When we've talked to our employers and our insurers in the state, they say that they actually don't have enough information on their claim form to know that the service was being provided in an outpatient department as opposed to on the main campus. And so one of the light touch approaches that we're going to take on this is actually just require kind of honest billing, and that when you submit your claim form, you say where the service was actually performed. And we'll see if something maybe that light of a touch can help resolve the problem just by providing more information.
Yeah, and I think that there's two things with site neutral payment. So site neutral payment refers to the policy of paying the same price for the same service regardless of what site it is delivered. Is it delivered in an outpatient setting, in a physician's office, or is it delivered in a hospital outpatient department? And right now, under Medicare payment policy, Medicare pays more for the exact same service if it's delivered in a hospital outpatient department. And you can classify your physician's office as a hospital outpatient department just by buying that physician practice. And so that is driving a lot of sort of the vertical consolidation that we're seeing of health systems buying up physician practices, because they can take advantage of site of service differential payments, or basically non-site neutral payments, in order to make money. And it's not providing any additional value. It's not different services. It's the identical services in some ways. And so the idea here, and Medicare's been pushing on this from the federal level, and we're seeing increasingly states becoming interested as well in using a sort of saying, why should we pay more for the exact same service? If it can be safely provided in a physician's office, then we're going to pay the physician office price. We're not going to pay extra facility fees, nor are we just going to pay a higher professional fee just because it was delivered in something that's technically classified as a hospital outpatient department. And the data piece is the first foundational building block, because as we know, as Charles said, you can't tell just by looking in claims data necessarily. Most states can't tell which services were provided in a physician's office. It's all billed under the hospital's NPI provider number. And so it looks like it was billed in a clinic in the hospital wing, but it wasn't. It was just a physician's office visit. So I think part of this is an information gathering approach. There was definitely momentum at the federal level to implement site neutral payment, but also states are increasingly looking at ways to both limit and curtail facility fees, but also prevent to even look further and see if there are ways to implement site neutral payment at the commercial plan pricing level, to basically say, we're only going to pay, that plans are empowered to only pay the sort of safest outpatient rate, the physician fee schedule rate, whether that's pegged to Medicare, but whatever the sort of physician rate would be for a physician visit, that is what I think most payers are in agreement. That's the price that should be assessed. But right now we can't even track how much non-site neutral payment is happening.
Just want to put a fine point on one thing. It's not just that the health plans pay more, it's that patients often pay more, because patients are often facing high deductible plans. And so when they go to a hospital outpatient department, which they may not even know that they're going to one because it looks like a physician office, may not be anywhere near a hospital, and they're just going for a regular doctor's office visit, and they're going to pay more in their deductible and their copay or whatever out of their out of pocket. So it's not just that the health plans pay more, we're paying more. And what is the value that's being provided from it? So to me, fixing facility fees, that's pro-consumer and pro-competition.
And to get on the lack of patient knowledge on this, patients are supposed to have preventative care covered at 100%. And you could go into one of these visits, it's for preventative care that you shouldn't have any out of pocket for, but then you get that facility fee bill. And so it's actually circumventing one of the core protections of the ACA, which was that preventative care should have zero cost sharing.
Thanks. David, I did want to ask you about the situation happening in Massachusetts now with the bankruptcy of Steward Healthcare, which owns hospitals across the state that could now potentially be facing closure. What is what's playing out with Steward say about industry consolidation and private equity investment in healthcare?
Whew, that's a big question. All right, where to even jump into that? So yeah, as I'm sure many people in this audience, I'm sure know, Steward Healthcare, a national healthcare provider, headquartered in Texas, but has a large presence in Massachusetts, Texas and Florida, but a large presence in Massachusetts, recently declared Chapter 11 bankruptcy. They have 8 hospitals in Massachusetts and a large physician presence in Massachusetts. This is obviously big news in Massachusetts. And the future of what will happen with the hospitals, which are by and large community hospitals that typically serve a larger percentage of Medicaid and public payer patients. And the physicians attached to the Steward system is top of mind for our healthcare system right now. I think this, there's a lot of history with Steward, which I don't think we have time to go through in detail today. But it does raise, I think, a larger question around the role of private equity in healthcare. There was a role for a private equity firm, Cerberus, in Steward Healthcare that had a significant investment. The Steward Healthcare system sold the real estate assets of its hospitals to a real estate investment fund. The private equity firm subsequently exited with a significant return on its investment, which has been reported publicly. And ultimately, the debt and the lease obligations added up and left Steward in a financially precarious situation, which has led to the bankruptcy. That is a very, very quick, short telling of the story. But the questions it raises to me, specifically relating to private equity, that is different than other types of investment, is the really focus on rapid return on that investment, the focus on using debt and selling off of significant assets in a rapid way to garner those rapid returns, and the lack of transparency that I think the state and federal government have on these activities. We just tried to understand in Massachusetts, where has there been private equity investing in healthcare? And there is, again, no such database that exists that can tell you that. And so we had to buy kind of a proprietary data set that public traders use and investors use. And this proprietary data set that was not cheap. Basically, what it does is it goes and just does Google searching and finds press releases from private equity firms where they're touting, oh, we invested in this dental practice. Oh, we just bought this autism services provider. Oh, we just bought this IVF clinic in Canton, Massachusetts. I'm just making that up. But again, there's no transparency at all about when these investments are taking place. And they can often be, an investment and then an exit and a sale to another private equity firm. And I think there just needs to be at a baseline much more transparency about when these transactions are occurring. And in the case of the Steward situation, we, and I mentioned before some of the limitations that we have about what transactions get noticed to us for review. We had no notice that they were selling their most significant asset, the real estate of these hospitals. And that was not something that was put before before us, the HPC, for review. So baseline, we need to have more transparency about when these are happening. We need to have some of these significant transactions, which we know will have significant impacts on market functioning in the future, be put before the same types of transactional reviews as other types of transactions. And I think we need to think about much more transparency on a kind of a corporate and financial level about financial performance and the debt. And I think state and federal governments, we need to get smarter about understanding these complex financial structures, because the finance side of this, they are outpacing our ability to understand this. And they're using this as to get beyond government oversight and leaving government in a place where now we're having to pick up the pieces of a failed healthcare system.
Thanks, David. I see we're running out of time, but I did have one last question that I wanted to pose to each of the panelists. If you could each just take maybe 30 seconds to answer. As the federal government is considering the impact of consolidation and private equity on healthcare affordability, what's one thing you would want federal policymakers to know or do to improve affordability?
Transparency of ownership. David just laid out a great case for why that's needed, but this is also a core bipartisan, nonpartisan issue. And by providing states with this data, you can allow the independent states to take their own path. There are redder and bluer versions of what you can do with that information to address the growing problem of consolidation, but that information is key to start with.
And I would just add I would second that and say that for transparency and ownership, I think David made a good explanation about just how complex these corporate structures are, so that they can't be defined simply as who's your parent company, who's your corporate owner, because a lot of these are contractual affiliations. They are management services organizations. They might look, particularly the physician practices, as though they are owned by a physician to get around the corporate practice of medicine prohibition, but they are in fact functionally controlled by contract through a management services organization that's either run by a private equity firm or an insurance company like United Health Group's Optum. And so the way you structure your ownership transparency has to be very nuanced and also very specific, that it is not just your owner, like who outright owns you on a corporate org chart, but who's your control entity and all the way up, and who's the control entity and who are the subsidiaries that are also controlled by the same ultimate controlling entity. And I think that's going to be a very difficult undertaking, but that's the kind of level of information we need.
I've got nothing to add. I'll cede my time. I've already talked
Yeah, I
too
think
much.
you covered it in the
Yeah.
last question. Okay, well, great. Now we are going to turn to our audience Q&A, and I'm going to invite Stacy back up for that. So if you have a question, just raise your hand and we'll have someone run a microphone over here.
Hi, I'm Sarah Hansard with Bloomberg Law. I think this could be for anybody, David, but I think, David, you might have been talking about it. I don't quite get, why is it in the interest, particularly of nonprofit hospitals, to take on private equity groups such as anesthesiologists or whoever? Why did they change that, now that they're charging so much more for those services? Anybody? What's in the, how is it in their interest to do that? Because most hospitals are nonprofits.
So I think if I'm following the question, I think there are some hospitals that truly don't have a choice. If they are needing to staff their emergency department, needing to staff anesthesiology, we call them the ERAP providers.
They still do so by contract. And so it's like, who are you contracting for that service? And if the staffing company in your market is basically consolidated and now it's all private equity owned, then that's your only option in town. If you want to staff your anesthesia, then you got to do that. So I don't know if the question is, why do hospitals contract with private equity owned? If you look at the FTC versus US Anesthesia Partners complaint, it's a very good illustration of the market dynamic that hospitals find themselves in when they are dealing with a private equity consolidated anesthesia market. And what does that do to the hospitals who need those anesthesia services, but are reduced in terms of choice of who they can turn to staff their anesthesia departments?
Thank you. This has been a great panel. Charles, first of all, congratulations on getting the anti-competitive contracting
Thank you.
bill passed last year. Could you say a little bit about how that new law is going to be enforced?
So in our state, strategically, we chose not to put enforcement in a particular office because of political concerns. That's not always necessarily going to be the best approach. Some states are going to want to have active agency oversight of that. Ultimately, the way that this will probably be enforced is through the courts. And an employer who is trying to implement some new innovative benefit design is going to run up against some illegal contract term in their benefit contracts, and they're going to have to either just go ahead and do it anyway, and then force the person on the other side of the contract to sue them, or they might go in into for an injunction on the first side. But that's how enforcement is likely to happen. It will be a little bit messier, but we thought that the employers were more likely to take action themselves than we were to get our agencies. But that's our own state's situation, and other states may have a different approach to that.
Question over here.
Hi, thank you for this great panel presentation. So how do you educate patients on this consolidation and how they can know who they're seeing and what the facility fees are? In the example of the anesthesia practice that was just mentioned, you try calling the hospital and asking if your anesthesiologist is in network or a consultant or anything, they won't tell you that. So how do we educate patients? Thank you.
So part of this is that we can provide more information in real time than ever before. And there is a technological change to this that has really occurred where we have widespread mass adoption of apps that can produce this. And we now have laws, some of which just took effect this January, that can provide that transparency information. So if you have commercial insurance, you should be able to look on your insurance app, and you should be able to look up a service and get a geographically sorted list of providers that are in network with that pricing. Now, that's not perfect. They're not working great right now, but we are in early days of this. And I think that it's going to be a twofold response. One is creating the requirements so that you have these conditions for patients to use them. And then the other is building that patient demand through education. There are some heartening statistics here, and it is that there are widespread generational differences in desire to shop and comparison shop. And the younger generations expect this more than generations who are kind of trained not to shop in healthcare. So both through that, creating some of the supply and building some of that demand, we might see some change, but it's not a perfect solution right now.
I think we have a question right up here.
Hi, Joyce Frieden from MedPage Today. I wanted to ask Ms. Sanders if she could elaborate a little bit more on enforcing the hospital transparency provisions. Are you sending out more people to look at lists, or just what is happening there? Because I think a lot of people have questions about trying to figure out what their bill is going to be in advance.
Sure. Yeah. And I'm happy to follow up specifically and connect you to our colleagues at the Centers for Medicare and Medicaid Services who oversee that. I think what I will just say on that point is that in last year's hospital outpatient payment regulations, we took a lot of actions to increase transparency and enforcement of that program. And CMS also took action on their own to ramp up enforcement so that we can ensure those prices are made available as required under the regulation. And that was in large part because we were hearing directly from advocates and from folks who were concerned that the regulation wasn't living up to its full intent and its full promise. And so I would just come back and say, and again, we can get you more specifics, but it's really important that the folks in this audience speak to us about where transparency is lacking, where we can fill in gaps. I've heard some ideas from our panelists today that we're going to take back to the agency. And that feedback loop, I think, is going to allow us to really strengthen our efforts. And the hospital price transparency provisions are one place where we did just that. We heard about a need to strengthen enforcement, and we followed through regulatory action.
Other questions?
Hi there. You've all made very compelling case for why action is needed right now in this area. And I'm wondering if you can kind of elaborate on the political barriers to getting that accomplished. Why isn't every state taking on all of these reforms, and what information would be helpful to have more success in the future in this area?
I mean, politically, the answer is easy. We're trying to take money away from an industry that makes a lot of it, and people don't like having money taken away from them. So that is honestly the biggest obstacle. It's not conservative or liberal ideology. It is the fact that we have an industry that is making a lot of money, and we're trying to lower the prices that people are paying for it. And it's as simple as that.
And it often takes a crisis to motivate the political will to overcome the sort of objections of the entrenched industry. And the steward crisis is one of those, right? Where you see it sort of wakes up the public to what could possibly go wrong. But you also see that in other states where it may not be as dramatic as the Steward collapse, but it might be a big merger comes to their shores and everyone freaks out that there's no one who has the authority to stop the transaction before it closes. Or the other, I think one of the challenges is also just educating the policymakers about how much this is a problem in their state. And that goes back to the lack of transparency, because policymakers are like, okay, if I'm going to take this on, if I'm going to be, fighting this political fight, how much is private equity already here? How much, how many of our docs are owned by a health insurance company? How much is for profit? And the answer is it's very difficult to give anyone that answer because there is no transparency. We have no data. It's very difficult to be able to tell a policymaker, this is a snapshot of where we are today in your district, in your state. And so I think not that, again, transparency doesn't solve it, but without it, we can't even start to have that conversation.
Yeah, I think that's why I'm particularly a big believer in this idea of setting measurable goals as states for moderating healthcare spending growth as a first step. Many states have taken that on, and after Massachusetts, there are now 8 states total that have this kind of, let's set a goal for healthcare spending growth. And that can be a really nice first step to say, like, let's just measure something and track it. And once you start doing that, then you want to say, okay, well, what's driving it? And then you want to get a little bit deeper, and you want to get a little bit deeper. You want to understand, and that can create this kind of self-fulfilling momentum of just investigation and research and evaluation and pulling on different threads that can bring policymakers and bring the public along on kind of a narrative of understanding what is driving and what is contributing to our high healthcare costs. And so I think that is always a good way to kind of start these conversations, is just kind of starting with something tangible and then getting deeper and deeper and deeper into it. I would also say, and Aaron alluded to this, our legislature is considering new policy reforms as a result, and I think in reaction, well, they've explicitly said in reaction to the Steward crisis, that would enhance the Health Policy Commission's market oversight authority to bridge some of the gaps that I mentioned, and to strengthen our relationship with the Attorney General's office, so that when we even do find in our reports major concerns, that the Attorney General's office would have a stronger hand in considering that a violation of consumer protection law. So there is that reaction and that kind of evolution that is part of our healthcare reform journey as well.
And I'd just like to answer that question with a bit of a hopeful take. There's undoubtedly challenges, but I think it is so meaningful that you have a president that has stood up a competition council, that has announced in December that tackling healthcare consolidation is a priority, and then has brought to bear to this problem the power of 3 federal agencies. And what I would say, to kind of flip that question around and talk to you all about what would be most helpful to us, is really prioritization. Like, even in this panel today, we have heard about so many different pockets of consolidation, so many different issues that we could tackle. And I think that it would be incredibly helpful to overcoming some of those political challenges to hear from the broader community, this is the thing, these 3 things you should focus on and would be the most impactful in terms of promoting patient access and lowering costs. Because there is just the vastness of this agenda. It came through in my remarks, it's come through in this panel. And I think there is a need to focus the energy of this administration and of these agencies in the most constructive way. And we are very open to that feedback.
Question over here.
Yeah, hi, Mike McCullough with Modern Healthcare. You're talking about okay. There we go. No? Okay. All right. You're talking about from a state perspective. I'm wondering what you can't do. What do you need from Congress or the federal government to do what you
Well, one thing that states have always struggled with is regulating the bulk of the commercial market that falls under ERISA, the Employee Retirement Income Security Act. And so a lot of the tools that states have to be sort of provider focused. They have to be in the sort of provider regulation, and then you got to take on the battle. But when you actually want to get at those contracting practices, or you want to get at the commercial health insurance market that is employer sponsored, particularly self-funded employer sponsored, because of the breadth of ERISA preemption, states have very limited, not only tools, they have no insight. The state all-payer claims databases are not getting self-funded claims data because of the Supreme Court case Gobey versus Liberty Mutual that said states you can't ask for and you cannot require self-funded plans to contribute their claims data to a state all-payer claims database. So it's actually a state some payer claimed, most payers claims database, but this important chunk, right, which is the employer sponsored market, which is where most people in the working age population get their coverage, are not included. And so states have missing not only data, but missing leverage over this very critical chunk of the commercial market. And that's where in some ways states have to be creative. Like they are very creative about how to get at that, kind of get their arms around those parts of the market, but there are very limited tools. And that's where the federal government in some ways needs to step in or be a partner or in my wish list, modify the terms of ERISA preemption to give states a little bit more running room, because when ERISA was passed in 1974, 4% of employer sponsored plans were self-funded. It's only because of this giant sort of, exception that self-funded plans don't have to comply with state law that we have the situation that we have today. So I think that there is a huge blind spot there, and it's the self-funded employer market.
To give one specific example of where we would like to engage as a state and we can't because of this ERISA preemption, we hear from our employers who want to go around and create these innovative benefit designs that they go and ask for their own employees' data from their TPAs, their ASOs. These are the insurers that they hire to run their programs, and they can't get it. And so because they're unable to get that data, and it's, any number of different reasons. First, they'll claim it's proprietary, then they'll claim it would violate other contracts. But as a state, we can't go and regulate that problem. That is something that needs to be legislated by Congress so that it can empower employers to go create these benefit designs that will foster competition. And that is a uniquely congressional problem.
Yeah, over here.
Their skepticism of the ultimate effectiveness of transparency, at least at the limitations. There's a tremendous amount of complexity of not only obtaining the information but also internalizing it, right, and educating consumers about it. We all talk about competition as if typically as if it's all about price, but there's other kinds of competition, right? And so I'd like to hear, there seems to me to be quite a bit of evidence, both internationally and from different states and periods of time in the US, that if you combine regulation of prices with competition on other things, can flourish, like on quality, on service provision, on access. And so this kind of idea of, listen, maybe we should stop talking so much about price competition and be talking about what we can gain in other forms of competition if we combined it with price regulation or limits, whether they're out of network limits or across the board. I'd like to hear your thoughts on that.
I mean, I think that that's an important point. And one thing is we think about competition policy as primarily sort of like antitrust, of like preventing mergers. And then but the reality is we already have consolidated markets. And so what do you do if you're a state or a region that has highly consolidated healthcare markets? Well, the only option left is some form of regulation of price and other forms of ensuring access and ensuring that key service lines don't close, which is a byproduct of consolidation, that facilities, particularly low low profit margin, in other words, low reimbursement services often get closed first as a result of consolidation. And so you see, yes, quality, access, all of these other things, equity suffer when we have consolidation. So I think that the idea of sort of comprehensive state oversight, I think that the Health Policy Commission looks at all of those other factors. It doesn't just look at price, it looks at the impact on equity, access, quality, workforce, et cetera. And I think that that's an important lens for particularly state policymakers, but especially, and even federal policymakers to look at, which is to blend this sort of idea of like that price is the ultimate signal with these other desirable goals when we craft our competition policy.
Yeah, and just as an example of that, one of our most recent big mergers, a merger of our #2 largest system and #3 largest system, we issued a big report and found concerns about market leverage and a number of other things. And our Attorney General's office, ultimately, the merger did go through, but with a very significant set of conditions, which included price restrictions, but also conditions around investments in behavioral health care, investments in outreach to Medicaid and public payer patients, investments in community health centers. So I think that's a kind of a marriage of both price restrictions, but also let's also see you work better on accountable care and behavioral health and community-based care. And so what if that was not just in the case of a merger, but what if that was something that was more universal to a market? One could imagine that, and that system has been functioning very well under those set of conditions. So one could imagine that being something as an example for wider use.
I would say competition based on value is the key, and value is a combination of both price and quality. I think that there's two reasons why there has been such a focus on price, and one of them is practical and the other is more theoretical. The practical reason is that price is objective, whereas quality is more subjective. And everybody can agree what the price is on something, and so it's much more susceptible to regulation. It can be released. Quality rankings disagree with each other. If you try to get a bunch of providers in a room and ask them to agree on a quality ranking, you're not. And so there are inherently different things that different people, different actors, different systems are going to value when it comes to quality, and so it is much less susceptible to regulation. That being said, there is this theoretical basis that if we make prices more transparent and force the price variation that exists to be more widely known, that will inherently cause providers to now start advertising and promoting why it is that certain providers are more expensive. Well, it's because we have higher quality. And they will then figure out how to appeal to what it is that people value in terms of that quality. So that remains to be seen. We're still in the early days of price transparency, but that's at least one of the theories for how that quality component can come to the fore, is that individual actors will start promoting that once the price variation is revealed.
I think we're going to wrap it up there since we're out of time. But thank you to the audience for those great questions, and thank you to the panelists for the discussion. And I'm going to turn it back over to Karen.
I'll just echo Kelly's thanks to our panel and thanks to all of you for joining us today. As I mentioned, the recording will be available on the CHEER website if you want to come back and listen again. And please share it with your colleagues, and please join me in thanking our speakers once more.
Oh, sure. Renata actually has something from our more specific answer. Yeah.